Thanks, Tiasha. And my name is Beth Miller, and I am a director on the board of directors for the Scleroderma Association of BC. I'd like to welcome you all to our educational webinar series. Tonight's topic is pain management. And so we're having an information session with Dr. Micah Burns of the Change Pain Clinic in Vancouver. So Dr. Burns is a fellowship trained, board certified anesthesiologist and interventional pain physician. And he's going to share with us his perspectives on the science of pain. And he will outline some of the programs and services that are offered by the Change Pain Medical Clinic. The clinic's 12-month outpatient program is focused on providing layered care to patients with persistent pain. And the goal of this program is to diagnose the root cause of the pain, manage the pain at the clinic, and empower the patient to make informed decisions about managing their pain into the future. Dr. Burns has had a bit of a crash course in some of the aspects of scleroderma and how people who are living with scleroderma might have pain impacting their lives. And so he's going to speak to us tonight about that. And without any further ado, I will pass it over to you, Dr. Burns.
Great, thanks so much, Beth. Thanks so much to the Scleroderma Association of BC for having me. Much appreciated for this chance. So today I'll talk about scleroderma and biopsychosocial pain management. In terms of my disclosures, I'm not young investigator grant from 2020. I'm not important enough to have a lot going on there. Today we're going to talk about the biopsychosocial model of pain, and then specifically about scleroderma and pain, and then a little bit about how Change Pain Clinic can possibly contribute to your care. So all very important pain papers start with the definition of pain according to the International Association for the Study of Pain. So I'll do that as well, since this is very important, of course. An unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. I think a few things about that are important. So one, pain cannot be inferred solely from activity in the sensory neuron. So pain is a subjective experience that happens in a conscious mind. People learn about pain and their own individual concept of pain through their own life experiences. And a person's, in general, the way we think about it these days is that a person's report of an experience as pain should be respected as pain. And something that kind of stems from this definition in terms of chronic pain is that although pain usually serves an adaptive role, i.e. a protective role in an organism, it can actually have adverse effects on function, social and psychological well-being. So this picture is from 1664, Descartes, although this idea of pain as a purely biologic entity goes back to, like, I think they traced it back to like the Greeks somewhere, of course, like most ideas. They thought that there was a sensation. So this little angelic person is burning their foot next to a fire, and the pain signal goes up the leg, up the spinal cord to the brain. It's a linear course. They thought that more damage equaled more pain. If there was no damage, there could not be pain. And this idea still colors the way a lot of people think about pain now, even though we know it's much more complex. So the current model is this biopsychosocial model of pain. So we still obviously believe in biological pain. It exists. There's tissue damage, there's inflammation, there's immune responses, and there's things that help those things like medications. There's also the psychological aspect of pain. So mental health and anxiety play a big thing, but also an individual's ability to cope, and the skills of coping are important, things that can be taught. And then the social aspects of pain, so interpersonal relationships, support networks, and even societal beliefs. So different societies have different ideas about the role of pain, even in a given disease process, which can actually affect the pain that an individual experiences. And the difference really is that now we know that instead of being a linear path from the external sensation up this brain and spinal cord, and viewing the brain and spinal cord as just pathways and the end place of where the pain's going, we actually know that there's a lot more action happening there. So there's a big interplay between the brain and spinal cord and the signals that come up. The brain can actually decide not to respond to a pain sensation at all. And the brain can do this for all sensations, not just pain. And to give a personal example that comes up, you can be engrossed in an activity like reading a very interesting book, and someone can say something and you don't actually hear what they say. It doesn't mean that that they didn't say something, and that they did, and the sound traveled through the air and went into your ear and activated the same things it always activates. But that sound didn't actually rise to the level of your consciousness because your brain decided it was concentrating on something else, and that was not going to intrude on what it was concentrating on. And the exact same thing can happen with, hunger, cold, heat, and pain. And those pathways are unconscious. That is to say, they're not as controllable as as moving your fingers around. So that's a very conscious action, but they are influenced by the conscious brain. They're always present, and they're always functioning. But the balance in how powerful a given sensation will be is being decided by the brain, not the mind necessarily, but the brain, in a moment by moment basis. So a lot of psychological therapy is focused around harnessing those pathways to reduce the suffering from the experience of pain. And social supports are very important. Belonging to a group of like-minded people, such as this one, I think Beth and I were kind of chatting about beforehand, but having people that are going through a similar experience as you, providing support, decreasing feelings of social isolation, all that can be very important to reduce the suffering from the pain. And I think just a couple of definitions, because I think they help set a good baseline of understanding. So there's nociception, which is just the response of our body's sensory nervous systems toward actual or potentially harmful stimuli. So that's just the nerve signal, basically. And then there's neuropathic pain, which is described as coming from a nerve injury or nerve impairment. There's inflammatory pain, which is inflammation is just a natural response in the body that is produced in reaction to a harmful stimuli, and of course hijacked in autoimmune conditions a bit. But the substances the body produces during inflammation activate the pain nerves, normally as a protective mechanism. Then there is nociplastic pain, which is kind of another way of saying central sensitization. I think the kind of poster child for that is like fibromyalgia, which is pain without any sign of tissue damage, which people used to say was kind of all in the head. But now we know it's actually pain in the brain and spinal cord, as opposed to being some kind of made up thing. So there's biological pain, as I was saying, that people understand because you get a splinter, your finger hurts. Everyone understands that, right? But most people do understand the psychosocial aspects of pain. They maybe just haven't thought about it as broken down into those categories necessarily. So the general psychosocial variables that we think about in terms of pain are things like distress or trauma, or just broadly interpersonal factors as well. The pain-specific psychosocial variables are like expectations around pain and recovery, pain-related coping, and something called catastrophizing, which is kind of like, I have a hypochondriac aunt, if her stomach hurts, she has cancer. If she has a headache, she calls me and thinks she has cancer. But it's that always going to the worst place is the idea of catastrophizing your pain. And I think the reason that we like the biopsychosocial model, and that I hope you'll like it too, is because just describing the disease process doesn't sum up a patient's full experience. And the biopsychosocial model helps to more fully capture and describe the full experience of the patient. And that's important because then we know who we need to help. So just a few more definitions. Acute pain is anywhere up to 3 months, and chronic pain is pain that has lasted at least 3 months and then out to years. And that's important because if you have chronic pain, the chance of that nociplastic pain, that central sensitization, is a bit higher. So, and the treatments are different. But the biopsychosocial model describes pain and disability as a multidimensional, multifactorial dynamic, so changing interaction amongst these three domains. So how much each domain contributes to any particular patient's pain varies from one patient to another, and it varies within each patient over time. So why do we even care about pain? Well, pain is just a subjective experience that a lot of people find very unpleasant. And so we try to alleviate that pain because we have compassion for each other. And also because on an individual level, we want it treated because it reduces our function, it reduces our quality of life. I think in addition to the impact of pain on any given individual, that pain also affects who's in their family, the community, can affect their workplaces, health systems, and of course the entire economy. And so, although I think ultimately for me, it ends up being, I treat patients sort of on an individual basis. So for me, it's often just I'm looking at function and quality of life. Multidisciplinary treatment. So multimodal treatment, meaning different types of treatments provided by a multidisciplinary team who collaborate in assessment and treatment using a shared biopsychosocial model and goals. This is considered one of the most efficient and effective ways of helping patients with chronic pain being more than 3 months of pain, to reduce the severity of their pain and its impact on their lives. So as you can imagine, this just means like more than one, so like a physician and a allied health person, like a physio or something. There's good evidence that if patients apply the skills learned at a multidisciplinary service, they become more functional in their daily lives. They can experience improved mood, confidence, and sleep. Multidisciplinary treatment tends to promote self-management of pain by the patient. And it can offer the patients alternative ways of managing their own pain, which is certainly a lot of my focus. For example, let's say you have a mental health issue. Maybe a physician will prescribe an antidepressant. A physiotherapist will do some exercise treatment. Exercise helps with low mood. And a psychologist may work through a cognitive behavioral treatment program. And in multidisciplinary treatment, these people would all be working in their own offices, maybe through the same model, but not necessarily planning with each other. The next step up from that is interdisciplinary treatment. So same model, except in this case, interdisciplinary means that they work closely together with team meetings, with an agreement on the diagnosis and an agreement on plans for treatment. None of these are necessary for all patients. All right, so patients that have the most severe symptoms benefit from interdisciplinary care over multidisciplinary care. Because interdisciplinary care provides more coordination and communication. And a bit about layered care. So it describes basically matching the needs of the patient to the level of care that patient needs. Not everyone needs interdisciplinary care. Some people just need their GP or scleroderma. Maybe they need a rheumatologist. And yes, I did make this, and I'm very proud because it does show actual layers for layered care. So maybe let's say at the time of diagnosis, you get a physician, you have medications from a biological perspective. Hopefully everyone has a support network and is doing some self-management. You're going to the Facebook pages, joining a society like this one, and self-management, doing exercises, learning, that kind of thing. And then having access to a mental health counselor when it becomes necessary would be the next layer of layered care. Same thing for movement therapy. You notice that you need some more hand, your ability to grasp things is decreasing, or maybe your doctor notices, your family member, and you want to have access to a movement therapist who can give you some of that function back. And I fit in kind of here way at the end as a specialist referral, basically for like symptom management. So when you or your GP rheumatologist see that there's maybe room for improvement, want some advice on how to proceed, then maybe I can offer some help, and I'll tell you how I think I can help later on. So the biopsychosocial model as applied to scleroderma. So there was a longitudinal study that took place over 3 years. As they took the same patients and just studied them at different points in time over 3 years. And they found that over time, actually pain changed very little for any individual patient. If it did change, maybe it actually just improved a bit. And that's despite, you would assume, some sort of disease progression happening. And a potential explanation, according to authors, for this kind of paradoxical finding is they thought a recalibration of expectations, a change in values and priorities regarding the pain of the patients, or even a changed conceptualization of what pain is. And in that longitudinal study over 3 years, patients consistently reported that a significant burden of their pain was linked primarily with their psychological and social aspects of their life. As in, patients didn't often blame like disease severity for their pain. This is a cohort study. So they just a snapshot in time as opposed to doing over time, right? So a slightly different way of looking at things. If you look at the bottom left there, it says skin thickening and forced vital capacity. Those are objective measurements of disease, like where the disease process is in a given patient, like how much disability they have. As you move over, there's perceived physical health worry, mental health, and social support. And they got those numbers using surveys. So it's just patients answering questions about what's going on. And so if you think about the right side as more kind of mental health aspects of pain, and the left side being more physical aspects of pain. So 80% of these patients reported having pain. Not surprising in systemic sclerosis, right? A large proportion also reported symptoms of anxiety and depression. Not shocking either, I think, for anybody that is around anybody with chronic pain enough. You see that. So the patients were given a physical exam to look at the clinical extent of disease and took these surveys. So they did ran a bunch of fancy math stuff and came up with 3 classes, and that's what those lines are. And it's a bit hard to see, so I hope this helps, but this green line shows that black line across the top, and those are the patients that they deemed as managing. So these patients had decent physical function and also decent mental health. So just kind of doing okay across the board. This group of patients were those that they deemed distressed. So you can see on the left side, they're actually doing pretty well, physically speaking, but on the right side of the board, they're actually doing poorly from a mental health perspective. So they're distressed patients. And then there's the resilient patients that were doing poorly physically, but actually doing fine from a mental health perspective. So I thought that this was interesting because there was about equal systemic and limited cutaneous sclerosis in the different groups. So they actually went back again and looked at more stuff about disease severity, like digital ulcers, and they actually found no difference between the managing and distressed groups. So disease severity is not the main driver of the differences here. The difference was that the distressed group had much lower social support. So their friends, family, social network that support the patients while they're going through, having this disease. That lack contributed to a lot of their pain. So just a summary of that is that of those two kind of studies, in my mind anyways, that a lot of people with scleroderma have pain. The extent of disease does not necessarily equal amount of pain, and a lack of social support in those two different studies, looking at over time, but also as a snapshot in time, lack of social support was one of the main determinations of pain levels. So not all patients respond to pharmacologic pain management, like just throwing drugs at patients. Obviously, they have their place. I think they're very useful. I'd use them all the time. But there's other methods that target modifiable psychosocial factors, and those should also be considered. Something like cognitive behavioral therapy, which involves skill building in like mindfulness, relaxation, coping, changing maladaptive beliefs. They've been used in other pain populations and has been shown to be effective in at least one study with scleroderma that I found. So I wanted to use that to demonstrate the utility of the biopsychosocial monitored care. We're not just looking at objective measures. We're not just looking at subjective measures. We're not looking at, just, how much, what's your lung capacity. We're not just looking at what you say your mood is. We're looking at the whole picture of the patient, and that allows us to target care in, I hope, a better way to really help the people that need it. And I hope that those two, if you're not already convinced, I hope that helps you as a patient to believe in the biopsychosocial model, so that when, for instance, as a physician, if I say, you should do this education event or whatever, something like this, that you see it as part of a treatment of care, not just some useless thing and all you want is drugs from the healthcare system. Patients have a very active role to play in their own care, and there's a lot that you can do for yourself and also for other people from a social perspective to improve everyone's, I think, experience. So obviously, I fully believe in self-management as much as possible. That doesn't mean that I can't be useful, I hope. So my kind of interventional pain toolbox, my toys. So there's medications, both topical, like creams, things like acetaminophen or ibuprofen, or NSAIDs, nonsteroidals, and then opioids, rarely enough these days. Thank God, but they do have their role. And then things like neuropathic pain medication, so tricyclic antidepressants. You've heard of that maybe as amitriptyline or nortriptyline. I use antidepressants for pain. Antidepressants just change the way that neurons talk to each other. They were originally studied for antidepressant, so that's what we call them, but really they just are neuron changers. And then we use things like anticonvulsants, sodium channel blockers, basically like gabapentin or pregabalin Lyrica, if you've heard of those. And then a large portion of what I do on any given day is nerve blocks, injections, epidurals, nerve ablations, and then things like infusion therapy, always with the goal of helping to keep people functional, and almost always in conjunction with another doctor as well. So like I see a lot of arthritis, so I knee, hip, shoulder pain, which I'm often co-managing with allied health, kinesiologist, physio, a GP, maybe an ortho. I see a lot of headaches, so neurologists or GP are kind of co-managing together, right? So everything is teamwork for us. So one thing I thought was interesting was neuropathic pain in scleroderma, thought to be a bit underdiagnosed. So in one study, there was About 70% of patients had pain in this study, which basically matches what a lot of other scleroderma pain studies would say. And half those patients had neuropathic pain. And that's described as a burning, tingling, pins and needles type of pain, as opposed to maybe sharp or aching or dull. So different descriptors from the patient actually help differentiate what kind of pain it is. And that's all validated in big studies. So they really are useful, your descriptions of pain. Those that had neuropathic pain actually had higher pain scores. There was the same incidence of neuropathic pain between systemic and limited sclerosis. And neuropathic pain was generally associated with a lower quality of life in the surveys. It is a different type of pain, requires a different type of medication, usually not just acetaminophen, ibuprofen, and opioids. As I said here, the neuropathic pain medications are their own couple different classes with their own, side effects and things that we use them for. Hand pain is obviously a pretty big subject in scleroderma. It's actually where most of the patient dissatisfaction and disability comes from, according to a lot of my reading. And scleroderma has a bit of a paucity of studies around it, unfortunately, but the ones I did find were mainly around hand pain in terms of the stuff that I can do. So there's a couple different reasons for hand pain. There's vasospasm, digital ischemia. So lack of blood flow is ischemia related to vasospasm, of course. Tenosynovitis, so inflammation and pain of the connective tissues. And then nerve entrapment, thought to be from fibrosis near the nerves, which can kind of entrap them in a layer of tissue. So possible treatments include, of course, medications that increase blood flow, which you'll all be somewhat familiar with, depending on where you are, I suppose. And then there's things that I do or surgeons do that are mainly focused on preventing vasospasm. So like sympathetic blockade, so blocking the sympathetic nervous system. And then there's surgical techniques to block the sympathetic nervous system. There's microsurgical revascularization, so changing the actual course of the vasculature in the hand to increase blood flow. And of course, some hand pain is due to fibrosis of connective tissue, so maybe some nerve entrapment there. And one thought is that hydrodissection, meaning spreading of the tissues using fluid, can help relieve some of the discomfort on an entrapped nerve. So there is some evidence. This is an injection specifically to the median nerve, which is one of the three nerves that go to the hand. And it's very easily entrapped in anybody, really. It's what's known as carpal tunnel syndrome, which maybe you heard of. Causes a bit of numbness and tingling in the three fingers, thumb, and the first two fingers. And in one study, they did a hydrodissection, so put some fluid around the nerve and put a bit of steroid, which reduced patients' pain scores by over 50%, and that lasted for 8 months on average. It also reduced Raynaud's attacks and helped with some healing of the digital ulcers in the majority of patients, although it was a small study. They thought that it was maybe a combination of hydrodissection, freeing the entrapped nerves, arteries, tendinous structures, and maybe some corticosteroid, the steroid-induced reduction of inflammation. So of course, we have to be careful with steroid in scleroderma for kidneys. But I, for instance, have a technique where I do this with just a dextrose solution, so just a sugar solution for people with idiopathic carpal tunnel syndrome, so like non-scleroderma related carpal tunnel syndrome. And it's really useful for that because just dextrose itself, the sugar, can help reduce pain of the nerve. And this technique avoids steroids, which I think is really important. And there's other things we can do to kind of elongate the effect. The other nerves are the ulnar nerve, which is kind of that funny bone feeling if you ever hit your elbow wrong. And it can be entrapped right at that elbow, which can cause some pain down the pinky side of your forearm and into the pinky and the hand. And that can happen in scleroderma as well, some entrapment. So that's one thing that I think would probably be useful, is the hydrodissection. So I mentioned blocking the sympathetic nervous system. So this is part of the autonomic nervous system. It's basically everything your brain and spinal cord do that you don't have to think about very much. So breathing and your heart beating and digestion and the functions of your excretion. So the parasympathetic is on the right. It's nice and calm and green, and the signals come mainly from the brain stem, as well as your sacrum, which is the bottom part of your spine. If you take a big, slow, deep inhale while feeling your heart rate and you feel it drop, that's your parasympathetic system. It's calm, it's relaxed. It's, you guys have Thanksgiving here, right? I assume everyone eats pumpkin pie because it's amazing. So if you just think about, you just ate a big pumpkin pie and you want to lay on the couch, and that's your parasympathetic nervous system. Your sympathetic nervous system is fight or flight. So it's everything adrenaline does, epinephrine, faster breathing, high heart rate, constricts blood flow. It runs in certain areas. You can see on the right there. It runs kind of in the middle part of the spine, so the thoracic and lumbar spine. We do injections of the sympathetic nervous system quite often along the spine for various things. And you can also inject along arteries, because the sympathetic nervous system runs along arteries. That's how it affects how big they are, how it causes vasoconstriction. So if you inject around arteries, you can also block the sympathetic nervous system. So I do this a few times a week for various things like PTSD for people that have been in car accidents, or veterans that have PTSD. We block the sympathetic nervous system, makes them feel a bit calmer. Complex regional pain syndrome responds to the sympathetic nervous system. And there's even some evidence that long COVID, which causes a bit of imbalance in between these two nervous systems. So blocking the sympathetic can actually help with some of the symptoms of long COVID, maybe, anyway. So it's something that I'm very familiar with. It's been found to be effective in scleroderma. It's just a matter of how often do you have to inject, and at what point is it necessary to go through that. And that's something that you just have to have a risk-benefit discussion with someone like myself who does the injections, in conjunction, of course, with the rheumatologist who understands the process of the disease in more detail, of course. So just a discussion about when and why and how often, that kind of thing. I would assume that if someone is having severe pain, or even just acute pain from an acute vasospasm, something like this would be really useful. So a wrinkle in a forehead, God forbid, of course, it's Botox. So instead of using it for aesthetics, we actually use it for pain a lot. So I do it a lot for headaches, migraines specifically, or post-traumatic headaches. It's useful for muscle spasm, muscle spasticity, and also joint pain. You can just inject it right into a joint. So there was a study actually where they injected it around arteries to the fingers, because we all have two arteries that go up the side of the fingers with little nerves there. And they just put a bit of Botox around each artery of the fingers, and then followed them for 12 weeks. And 80% of the patients who they did that to actually showed an improvement in their symptoms, a reduction in pain. 65% of those patients, I think it was only 20 patients, so it's not like a huge number, but 65% of those patients showed an improvement in cold intolerance, had a stronger grip. And I think the downside of me even mentioning this is that Botox is not covered for this. You could ask PharmaCare for coverage, certainly, and sometimes they do cover it, but just on a case-by-case basis. So that's kind of the downside of the Botox, but the actual risk of any procedure with Botox is so low because it is self-limiting. It goes away in like 3 to 6 months, depending on what you use it for. Other options to affect the sympathetic nervous system, so blocking at specifically the stellate ganglion, which is at the base of the neck or at the second thoracic vertebrae, just with local anesthetic, can be really useful and actually last for days to weeks at a time in other pain conditions. And there's ways to elongate the effect of blocking the sympathetic nervous system. And overall, it sounds weird because it's next to the spine. Of course, it's what I do day in, day out, so it doesn't sound that weird to me. I would certainly reassure you that in the right hands, they're very safe. These procedures, they're all image guided. It's not just a blind, needle injection. So, just as like a last little thing, this was just a case report. A single patient. She was very young, had scleroderma, very quick disease progression. So they were just like trying things. So they tried a lidocaine infusion, a series of lidocaine infusion. And in this patient, single patient, they reported an improvement in pain, skin turgor, skin elasticity, and peripheral perfusion. So lidocaine does have anti-inflammatory properties when you use it as an infusion as opposed to an injection. So something so it's going into the bloodstream in this case. And the authors hypothesized it was the anti-inflammatory effect that decreased this patient's symptom burden. And we do these at Change Pain, although they're a private pay service. So continuing with the kind of biopsychosocial model, I'll talk a little bit about the psychosocial aspects of scleroderma and then how we can help at Change Pain with those. So this study talked about kind of the symptom burdens that patients experience and recommended, as we've spoken about, layered care, that is more care for patients that need more care. A lot of other interventions for other rheumatologic diseases involve self-management courses. And even though there's no evidence specifically in scleroderma, they sort of hypothesize it would probably be useful because it's generally useful for most pain conditions. So in terms of the depression, they noted a lot of patients actually describe their depression as a bit more transitory, so that they meet criteria for major depressive disorder maybe for a few weeks or months at a time, and then kind of lift out of it, as opposed to being sort of having it and then you have to be on treatment for 2 years or something. So it's something that kind of comes and goes a bit more. Same thing with anxiety and fear. So future anxiety, the future is very uncertain for those that have scleroderma. And so anxiety is often associated with a fear of disease progression. Totally normal. The authors note that, and I just want to reiterate that, like, it just sounds to me like anxiety around fear of disease progression just seems totally normal. It doesn't mean that it can't be helped, certainly, because there's skills around that that can be really useful. So there was a case study where within an interdisciplinary program, they took a patient and they implemented cognitive behavioral therapy. It's the only study I could find where they actually used cognitive behavioral therapy for a scleroderma patient. So they did a psychological intervention, but they also had an occupational therapist. They had a special nurse who had discussions with the patient around pacing for fatigue. So some education around how to best optimize life around fatigue. And at the end of the study, that patient showed reduced fear of disease progression, decreased scores of depression, and also showed a decrease in fatigue. And so to go a little bit more into that, because Beth told me when we were kind of discussing what might be important to the group here, she thought fatigue would be kind of something that people would want to hear about. So, and I did find, as they said in the study, that fatigue is the most common symptom in systemic sclerosis, and fatigue from chronic medical disease in general is characterized by a persistent exhaustion, disproportionate to exertion, and not relieved by rest. So if you've ever had activity, been very tired, rested, and still aren't and are still exhausted, still fatigued, that's this kind of pathologic fatigue. And I see this all the time at Change Pain. We have a lot of courses on pacing, and we have multiple courses on patient education, and they all touch a little bit on pacing. Pacing is basically paying attention to how much energy you can expend without going into that crash, not being able to get out of bed, basically. Crashing is usually associated with a pain flare, so big increase in pain. And so you have to figure out how much activity level is appropriate for you, that doesn't cause a crash, and you never or rarely, more likely, go over that level. Sleep is another big one, and there is some reduced sleep efficiency compared to age-adjusted norms in systemic sclerosis. And I think it makes sense. Like if you have acid reflux and you can't sleep, of course you got to treat the reflux, or you're never going to sleep. But a lot of issues with sleep are related to lifestyle, kind of modern day living, lights on at night and screens, etc. And worse sleep absolutely worsens the ability to deal with pain. And pain is almost always reported as worse at night. So if you're not sleeping, your pain's going to be worse. Then you're going to be in a bad mood, right? Because your pain was bad all night. So from a self-management perspective, it can be very important to learn about kind of the natural sleep cycle and ways that you can optimize your life around sleep so that you get more sleep. Just in terms of self-management, this was a really interesting study that they asked patients, what are the most important barriers to your physical activity? Patients named Raynaud's phenomenon, fatigue, joint stiffness and contractures, and difficulty grasping objects. Kind of the second tier was gut issues like gastrointestinal issues, itching and dry skin, pain and shortness of breath during exercise, and feeling embarrassed during exercise. So then they asked the patients that, and then they asked patients for ways that they got around those barriers, which they called facilitators. And then they told all the patients, they spread the knowledge of those facilitators and then had the patients try them all out and rate them, which I thought was just such a good study. So it's what patients have figured out works for them. And then someone else kind of helps gather that knowledge and puts it out there. And it was things very simple, some of it, right? Like you got Raynaud's, maybe you remember warm clothes, you wear gloves, keep gloves with you at all times. You have issues with balance, use ski poles for walks, exercising. Don't be afraid to use controlled, slow movements during exercise. Change your exercise equipment. So maybe using weights with large handles so they're easier to grip. Using moisturizer for skin dryness. My wife taught me that trick when I was like 30 years old. Fatigue or lack of enthusiasm, maybe use a social component or have social support. So like committing to exercise together, like we're all going to exercise this Monday together, take the same class together, whatever. So where does Change Pain fit into this? So Change Pain is a accredited, innovative, interdisciplinary pain center specializing in personalized whole person pain and rehab care. We use advanced neuroscience-based therapies in our very large and experienced team practitioners, passionate about helping people optimize brain and body performance, functional recovery, well-being, vitality. So we have multiple interventional pain physicians, people that do kind of what I do. So managing a bit more complex pain. We have pain-focused GPs who mainly do a bit of medication management, but also trigger point injections. And we have 2 fellows who are doing pain management with us and 1 GP fellow who's doing the trigger points. From a mental health perspective, we have 2 psychiatrists. The second one's coming soon. We also have a GP who does integrative medicine, and she's done a psychiatry fellowship as well. We have an internal medicine physician who specializes in central sensitivity and chronic fatigue. She has an integrative medicine background as well. Our allied health team is nurses, physiotherapy, kinesiology, chiropractor, acupuncture, pain coaches, yoga teachers. We're an academic practice. We have rounds just like this on a little less in the summer because everyone's on vacation, but usually we have them every Thursday. So we both from people inside and outside our clinic. So we're always learning about new resources that we can use for our patients, and also just learning about what we do from each other. We have a research arm. So most recently participated in a province-wide study on pre-surgical optimization. As I said, we have a fellowship, and we do, from an interdisciplinary perspective, we do case reviews. So on a bi-weekly basis, any of us can put forth anybody who works at Change Pain can put forth interesting or tough cases, and it's discussed with the physicians and allied health team to kind of help us get through tough spots and also make sure that we're all kind of working from the same knowledge base. Here's kind of our idea of layered care, which is one, everybody gets access to group medical visits. If you're a BC resident, basically it's all MSP covered. It's all through Zoom, so you don't even have to get off your couch. The next layer after that, for those that would like it, is myofascial release. So trigger point injections or IMS, also physiotherapy in chiropractic care, kinesiology, that kind of stuff. We do have group medical visits. For those that don't have extended health, we have group medical visits that are run by our movement specialists. So it's at least some access to movement therapy. If layer two isn't working, layer 3 is someone like myself who does kind of ultrasound guided injections, blocks, and layer 4 after that is infusion therapy. So we infuse things like lidocaine, ketamine, magnesium to reduce pain. Those are mainly aimed at central sensitivity. These are kind of the components of care, and each team member contributes to each one of those little petals, I would say. So for instance, I do like pain blocks and medication management, so maybe that's part of it, but I also give advice on nutrition and supplements, and I can do like basic sleep hygiene education with patients. Our core pain program is a fairly intense year-long program. People stay in afterwards, but we try to keep the intense part to get people often come to us what we would consider a bit late and maybe have decreased function compared to what we could get them to if they came a bit earlier. So we try and do a more intensive environment. So we see them way more often in terms of the trigger point injections, 1 to 2 weekly, doing a couple different GMVs to kind of learn about things. Very quick access to the interdisciplinary team. So moving up to someone like myself, within, I can see people who have been referred internally within a week or two. And we found that greater engagement in our process can help with greater results. And what does that look like? So it's patients often come to us kind of at this level 1 kind of, not everybody obviously, but patients take on that patient role, right? I've done it myself, no blame in any way, but it's just a natural part of it. At some point, like, you just want to be taken care of. We don't know that much about what's going on with us, so it's hard to be an advocate for yourself. Then you start to learn a bit, maybe make some improvements, maybe making some goals. Then you start to become a part of the team. You're learning some self-management skills, and eventually you're advocating for yourself because you've learned enough that you want to help make a difference. And this isn't to say that if you're engaged, you're like pain-free all of a sudden. It's just now you're goal-oriented. So we're able to kind of speak the same language and go in the same direction together, and help kind of towards the recovery process. So where a lot of that self-management stuff comes into these group medical visits, and they're all virtual. Like a lot of people during the pandemic, like a lot of our stuff went online, and then kind of exploded online because we didn't really have that much else to do, I guess. But they've stuck around because they're so well received, and we found them to be so useful. The one we've always had is this empowering you to change pain. So it's an 8-part series, provides self-management tools and strategies, and can connect you with resources both inside and outside change pain. So you kind of know how the clinic works, know how what other systems are available within Vancouver, Lower Mainland, to help you resolve or at least confidently self-manage your pain. It's really good for anybody that has chronic pain. We have yoga, Pilates, meditation, and all of our yoga teachers are very committed to pain, to yoga that is specifically tailored to pain patients. So a lot of this is extremely gentle. like appropriate for at times people that can't get out of bed. Like I can't remember, maybe Kundalini yoga is just basically a lot of breathing, which you're doing already, right? So you can definitely do this. There are some that are a bit more active, but really they're all just kind of restorative, right? That's the whole point of them, just to get people moving a bit. We have physiotherapy-led movement classes, as I said, so they're kind of broken down into different areas of the body. So a bit of anatomy, some introduction to basic stretching and strengthening of those areas, and then a chance to ask questions of the movement therapist. And one of these is pacing. As I mentioned, that is extremely important, and did help in that one study, the patient decrease her fatigue. But pacing is basically the cure for fatigue, or at least it helps reduce the impact of fatigue on your life. So it comes up in this, it comes up in empowering, it comes up in another one that I'll talk about. We have this weekly somatic therapy, which is, we have a lot of patients that have quite severe pain and have become maybe a bit dissociated from their body, for instance. And this can really be useful to help kind of feel your body again and get used to it and be and kind of, be present in your body, which can be surprisingly difficult for people when they've been fighting their body for so long. Sleep, we have a 5-part sleep series. Each of these sessions is an hour and a half, by the way. So if that get for all of these things, so if that gives you any idea of the depth of things that you don't know about sleep, Sarah Jameson knows, and she will tell you all about it. It's really, she's great. She's done a lot of work around pain, but also she's done a lot of work around how to get information to people, like from one person to another, not just like didactic teaching with like this, like a PowerPoint. She's like really good about making sure people understand. And she does the empowering course as well as several other ones. And the central sensitivity is another group medical visit that we have for anybody that has severe fatigue, symptoms like brain fog. You can look at that kind of little bubble of things like chronic migraines, temporomandibular pain, so jaw pain, restless leg syndrome, if you're like very sensitive when you take meds, that kind of stuff. That's central sensitization is kind of the catch-all for that stuff, but most especially fibromyalgia or chronic fatigue. Huge focus on pacing, like multiple days, like something like 4.5 of the, or like 3 of the 4.5 hours, or like 3 different days are associated with fatigue and pacing as a way to reduce pain, because it's so important. So this is how you get into change pain. Your physician refers you, and we can help manage what you're referred for, like as a team. We also take direct referral, so just for if you just want a specific procedure. It doesn't happen a lot, but if you just, whatever, someone wants an epidural or whatever, they can just send their patient over to us. Anybody can sign up for our group medical visits. You can just book online, just go to our website and book online. And that kind of gets you into the clinic a bit. And then, of course, for our rehab services, just like walking into any physio office, you can just kind of call and book. And we do direct billing of insurances, whatever. And then if you want a private pay service, you can just call and say you want to give us your money, I guess, and we will get you in. I think a summary of all of that, biopsychosocial model provides a fuller picture of how patients experience their disease, and also helps us focus care on those that need it. Mental health and social isolation make pain worse. Like that is poor mental health, I should say. Self-management and education are very, very important aspects of care. And not to toot our own horn, but I think Change Pain is an excellent resource to help with symptom management. Namely, this is not all the symptoms that people with scleroderma complain of, but these are some of them. So for pain, We have medications, various injections, infusions, movement therapy. Some of the mental health stuff that we do is going to be really useful. I think our fatigue, for fatigue pacing, I would, for anyone that is really suffering from fatigue quite badly, that central sensitivity group medical visit, I think is really, really good. And for sleep, optimizing sleep hygiene can only be helpful for anybody. So thanks so much for having me. I would, this would be the time for questions if there is time. I know it's 8. I did have a question. So Josh, should I just do that question, or Beth, or?
Yeah, feel free.
Yeah. So this was a question which I'll just say anonymously because I actually don't know if they want me to say their name, but this patient suffered an L5-S1 disc injury, so a low spine injury to the disc 6 months ago. They are currently recovering from their procedure. They noticed the nerve pain has improved. I assume that means there was a nerve that was impinged by the disc in the back, probably some pain down the leg, like sciatic pain. So that nerve pain has improved. However, there's been a resurgence of the scleroderma related pain. It was well managed with minimal pain meds, and now the joints feel stiff and sore despite taking hydromorphone, Tylenol, and Advil daily. So what has likely caused this flare up, and when should it get better? So glad that nerve pain is going away. I think that's really important. So anytime the body has pain in more than one place or more than one side, it makes the pain sums up to more than each individual area of pain. So if you had pain, let's say like in an elbow, in a shoulder, and I had this pain, all the pains are going to be worse. And especially when you've had pain for a while or the pain is very bad, you get that kind of nociplastic pain, that central sensitization aspect, and that can take time to recover from. Previously the pain was minimal and now it's a little worse. There is good evidence that taking opioids like hydromorphone, and also new evidence came out that drugs like Advil, non-steroidals, can actually elongate the amount of time that you have pain, and they can keep it going. So, for instance, in this particular patient, the surgery was in the spinal cord. So there's some inflammation in the body from pain, inflammation in the body from surgery, inflammation in the spine, because that's where the injury was. Taking hydromorphone increases inflammation in the spine directly, and Advil, while it decreases the level of inflammation, it doesn't actually allow the body to go through the active process of anti-inflammation to shut down the inflammatory system naturally. So it just kind of tapers it down, but then there's no resolution. So the inflammation just keeps going, albeit at a lower level. They can keep the pain going. So when should it get better? I don't have an answer. I don't have a timeline. Those are my answers for why the flare up. In terms of when should it get better, overall, my advice would be to do things like the physio, anti-inflammatory diet, try some supplements that are antioxidants that can help decrease pain. I would wean off the opioids first and work on things like gut health. So taking ground flaxseed 2 tablespoons every day is a really good start to help improve the health of the internal lining of your gut. The healthier your gut is, probably the healthier, the more well-regulated your immune system is. So that's like 4 things. Maybe that's enough.
Great, thanks, Micah. I actually have a question.
Please.
And it's a little similar because I've had an injury, a compression fracture. I have developed osteoporosis now. And so I've had a compression fracture in my L5, which seems to be healing fine. And I'm not having a lot of issues with it. And the pain has really pretty much completely resolved, which I'm very happy about. But what I do notice is that, I think given my family history, I'm prone to osteoarthritis as well. And I do find that I have a lot of stiffness, sort of increasing stiffness and occasional pain in my neck. I'm wondering, I'm assuming that at your clinic, you guys do a lot of work related to sort of arthritis and osteoarthritis, but what would your recommendations be for those kinds of issues?
Yeah. Assuming it's osteoarthritis, it could be things like myofascial pains, like the muscles and connective tissue around the neck can also be causing some of the pain. So you'd want to kind of differentiate those, which is often where something like trigger point injections come in. Because if they can give you any kind of lasting relief, then it's just from the muscles, really, which is good. Anybody that has arthritis benefits almost always from physiotherapy. Things like massage can help both relax the muscles and desensitize the tissues. Just being handled often can be really can kind of increase the endorphins, which provides pain relief. And then, of course, we're talking about kind of optimizing lifestyle and all that kind of stuff. And assuming you've done all that, and I can be of use. Usually there's a couple different joints in the neck, but the one that is usually implicated in osteoarthritis pain are the facet joints, which are just kind of run along the side. There's the vertebral column, which is like the big bodies where the discs is on the front part of the spine. There's a spinal cord. There's where the nerves come out of the spinal cord, and behind that is those little joints, and that's where a lot of movement happens. They're like little pivot points for the whole up and down the whole spine. And so it's very easy they're like little knees, really. There's little bits of fluid in there, there's cartilage. And just like knees, they can become painful with osteoarthritis. And they have little sensory nerves that bring the pain signals back to your brain. So what I usually do is, by the time patients make it to me, they've tried a lot of other stuff. So we can do test injections of those sensory nerves with just a freezing medication. Like bupivacaine, if you've heard of that, or lidocaine, kind of like when you go to the dentist and they do a little injection so you can't feel what they're doing. And if that relieves the pain, then that would tell us that the pain is probably coming from those little joints. And then we can do things like nerve ablations. So put basically the little sensory nerve, you can use heat, just a percutaneous, like a needle through the skin type of procedure. Put it next to the nerve, numb the nerve, of course, and then use heat to like burn a small section of the nerve. It grows back over the course of about a year, but during that year, the pain is usually significantly reduced. And we do that for neck pain, for headaches, low back pain, sometimes thoracic pain, although that's pretty rare. And then things like hips, knees, and shoulders all respond to similar treatments.
Okay, does anybody else have any questions?
On that
Um,
note, I'll stop recording and we can go from there.
Okay, thanks very much, Micah. That was great.
Yeah, thank you so much for having me.